Welcome to our live webcast, Taking the Mystery Out of Lower Back Pain, Evidence-Based Approach for the Primary Care Setting. Thank you for joining us. My name is Eric, and I'll be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all of your sent messages, and a smaller text box at the bottom where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, we ask that you complete a brief post-event evaluation. Please take a moment to complete this survey in order to receive credit for providing feedback and attending today's webinar. We are joined today by our speaker, Dr. Colin Harris, board-certified orthopedic surgeon specializing in spine surgery. He is new to us at AMG and is at one of our newest facilities, AMG Orthopedics at Paramus, New Jersey. At this time, I would like to turn the microphone over to our speaker, Dr. Harris, for opening remarks.
All right, thanks very much. I'm Dr. Colin Harris. As Eric mentioned, I'm a medical director of spine surgery at a new orthopedic office at Paramus for Atlantic Health System. And we're going to go over quite a difficult and challenging topic that I think all of us see quite a bit of, which is discussing how to take the mystery out of lower back pain and going over an evidence-based approach, especially for those in the primary care setting. So I'll go ahead and get started. Here are my disclosures. I do have some consulting agreements with Globus as well as Surgiline and Holo. They do some augmented reality things for spine surgery, and they're not relevant to this presentation. So the goals of the talk tonight will be to review the epidemiology and natural history of lower back pain. We're going to then go over some trends in evaluation and management and talk a little bit about variations between practice sites. And then we're also going to try to give you a really clear framework for evaluating patients with lower back pain, especially in a primary care setting. I'm going to start out with this. This is Hamilton Hall, who's a spine surgeon at the University of Toronto. He's a world-renowned expert in spine. And I went to a conference once, and his comment was really poignant to me. He said, "I'm one of the world's foremost experts on lower back pain, and I can tell you that I still have no idea what causes lower back pain." And I think this is pretty meaningful because if he doesn't know, it means that it's going to be very hard for us as normal people to try to figure this out. So we'll just keep this in mind that lower back pain sometimes, even for the experts, is very difficult to determine. So the burden of back pain, as you all know, it's a leading cause of disability worldwide. Generally peak stage is 50s and 60s, but it's the most common cause of disability in persons less than 45 years of age. It's also responsible for up to 10% of all primary care office visits, and this is from a Journal of Pain Guidance in 2017. This leads to an expenditure of over $100 billion annually in the U.S., which is a significant issue. Some of the challenges are that a very small amount of patients generally take up or generate 75% of the cost and resource utilization. Patient anxiety is common, and this is often reinforced by lack of agreement among healthcare professionals as far as how to treat these patients. And spinal imaging also has very, very high false positive rates. CT up to 30%, MRI up to 80%. So patients come in and say, "My MRI is a herniated disc. I need surgery, this and that." As you all know, very, very common issue. So let's look at some trends in lower back pain in the United States. So in the past 10 years or so, we've seen an increased utilization of imaging studies, more surgery, increased use of injections, increased prescription opioids, as well as increased costs. However, none of this has led to a decrease in disability, which makes us think maybe we're doing something wrong and we need some guidelines for how to treat this, and we need to standardize things a little bit. This was a Reader's Digest that came out discussing back pain new cures. This is about 15 years old now, but some of the things were suggested were an infrared belt for over $2,000, a magic spinal wand, percutaneous automatic discectomy, a flexible fusion, stem cells, a new bed, etc. So many things have been propagated to the public in general that creates this sort of misinformation about back pain. It's unfortunately extremely common. So let's look at what the experts might say about back pain. Here's a couple quotes. 80% of back pain is caused by weak or tense muscles. The majority of back pain actually originates in the sacral ligaments, and 50% or more, the facet joint is the site of dysfunction. 90 to 95% of back pain is due to discs. One person said an extremely high percentage have fascial problems, and another expert said 50 to 70% of chronic symptoms are psychological in origin. So you can see where this would become a very confusing issue, not only for patients, but us as providers as well. So we'll try to make some sense of this. Risk factors for back pain have been shown fairly clearly, and these include congenital spine abnormalities, and I'll kind of explain what that is, smoking, occupation, especially jobs with heavy lifting, and even some desk jobs where people have poor posture and trying to sit hunched over all day. That can also be a risk factor. Prior episodes of back pain are significant, physical unfitness, as well as age. Let's take a look at the lumbar spine anatomy for a moment. Many of you may be very familiar with this, but the lumbar spine is made of, essentially comprised of these vertebral bodies or building blocks. There's an intervertebral disc, which is adjoining it, made of the nucleus pulposus and annulus fibrosus, which is that outer ring. The facet joint in the back of the spine is really where we rotate, and there's extension and torsional type activities that go through here. The paraspinal muscles also can be injured, and then the ligamentum flavum, or what we call the yellow ligament, is here, and this is one of the primary offenders in spinal stenosis because it hypertrophies and then compresses the cauda equina. It's good to look at the spine as what's called a three-column functional spinal unit, or FSU, and this is the way that many spinal injuries should be looked at, because the majority of the weight bearing through the spine actually goes to the anterior column, or the front of the spine, where the vertebral body sits. Only about 30% of the weight goes through the back of the spine, or the facet joints and the posterior elements, and they're really meant more to tolerate tensile forces or stretching. So that's when the patient might be forward flexed. They might feel more pain in the disc, but they're actually stretching the ligaments in the back of the spine here. Lumbosacral transitional vertebrae are present in up to 30% of the population. This means that a patient may have 4 vertebral bodies. In the lumbar spine, they may have 6. This leads to number and confusion. It also leads to pain syndrome, such as Bertolotti syndrome, where here in the picture you can see that this patient has a pseudo-articulation here between a large elongated transverse process of L5, where they have a normal alignment on the other side. You can have this bilaterally, and there are a number of other transitional type segments that can lead to pain syndromes, and sometimes they can be incidental, which kind of complicates things even more, but it's important to look out for these. So let's try to go over a little bit of a step of evidence-based diagnosis and treatment of lower back pain in primary care. So the first thing really that you should do is, and the most important thing, is to listen to the patient's story, obtain adequate medical and social history. And this is very, very important. The next thing, you need to look for psychological and environmental factors that might impair that patient's recovery. Second step is to perform a directed physical exam, which should support or refute the findings in the history. And the physical exam for the lumbar spine should include inspection, looking for deformities, things like scoliosis, kyphosis, looking at how the patient carries himself, looking for pelvic obliquity or limb length inequality. All these things can be relevant. You want to palpate and try to determine specifically where the pain is. Sometimes it's nice to give the patients a choice. You can say, you can palpate 3 areas and say, is your pain at A, B, or C? That can be very helpful. You want to look for any step-offs, which may indicate a listhesis. And of course, you can sort of determine if the patient has scoliosis, especially with the forward bending test. Provocative testing is very helpful. It includes flexion, extension, and side bending. Straight leg raise, which we'll go over a bit more later, which is relatively sensitive for lumbar disc herniation. A femoral stretch test is helpful for an upper lumbar disc herniation, whereas a standard straight leg raise is helpful for a lower lumbar disc herniation. And then, of course, a good neurologic exam is critical. Waddell signs were described originally for trying to determine a patient's ability to return to work, or their chances of having centralization of the pain, indicating a less severe actual spinal problem, but more severe symptom. And these are very important. It was initially described at least 3 out of 5 were positive. And some of the things that we look for are tenderness. superficially, as the patient seems to be tender in a very wide distribution, non-anatomically. That means that a deep tenderness might be felt over a wide area. The patient may be overly sensitive. Simulation test means that we might rotate the patient's hip, or we may gently press down on the patient's head, and that may reproduce their back pain, which it shouldn't with any type of more serious spinal pathology. You can distract the patient by doing a straight leg raise in both the lying flat and seating position. Sometimes the patient may have a positive response in one, but not the other. Sometimes with a double leg raise, this should actually irritate somebody with a more serious spinal pathology quite a bit, but in the patient that may be centralizing the symptoms, they may get less of a response because they haven't been trained to look for that. Things like weakness and cogwheeling or giving way with manual motor testing are considered to be regional disturbances, and overreaction also is considered a Waddell sign. These are very important to look for. This is kind of an algorithm for evaluating patients with lower back pain, and this essentially is how to triage a patient. It's very important to remember that, again, most patients that you see, especially in a primary care setting, about 90% of them are going to have what we call nonspecific lower back pain, and we'll get into a little bit more about exactly what that means. But essentially, it means no clear pathoanatomical diagnosis. They have back pain. We don't know what it's from. We can't find anything on imaging, but they just have back pain. And this is actually a very, very high percentage of patients. And the pain is often muscular, but we'll get into later that really your focus on evaluating patients should be to determine which of these groups they're in and to treat them not necessarily by trying to localize anatomically where the pain is, but by trying to follow this algorithm. So patients that have nonspecific lower back pain, again, this is the majority, we move down and we want to assess for physical, psychological, social, lifestyle, and health-related risk factors. And there are a couple screening tools, and I'll go over briefly what they mean. But basically, there's one called the Start Back screening tool. There's an Arebro, and there's another one called the Pickup model. And these are essentially models of trying to predict patients who are going to have chronic symptoms versus the 70% of patients that are going to have acute pain and will get better. 30% may go on to have chronic pain or may be very difficult to treat. And so these screening tools are very good at hashing that out, so you don't have to guess. The patients are either going to score relatively low on the disability profile, in which case they will benefit from cognitive functional therapy. Usually 1 to 3 sessions might be enough to help them make sense of the pain. You want to gradually expose them to challenging tasks with controlling their pain, and also try to get them to lose weight, quit smoking, and do all the other things that we know will be beneficial for back pain. If the patient scores higher on one of these screening tools, and you get a moderate to high disability or complexity profile, in that case, we're going to still go through these same steps, but you have to understand that the patient is going to have a longer clinical journey, which could be 2 or 3 months. You may need to refer them for additional psychological support, pain management specialists, and they may need something called intermittent booster sessions. Going back to the top of the screen here, the next most common thing you might see is lower back pain with significant neurological deficit. And here we're going to talk about our herniated discs, stenosis, central stenosis, high-grade spondylolisthesis, and these things you're going to identify based on your clinical exam, and potentially you may need imaging to pick these up. These patients generally will need to be imaged. They may need a surgical consult, and especially if they have progressive neurologic deficits or any symptoms of Cauda equina syndrome, and we'll go through that a bit more. These patients need to be sent to a specialist right away, but again, this is a relatively smaller group, and radicular pain or pain down the leg or spinal stenosis are not emergencies themselves. However, if they have a progressive neurologic deficit, so they're getting worse or acutely worse, or if they have symptoms of Cauda equina syndrome, those would be emergencies. Then there's a very small percentage of patients which we want to really make sure we don't miss, and that's 1 to 2%. And these patients have cancer, they have inflammatory disorders, they may have a spinal infection, especially patients with a recent previous procedure to the spine, patients with any history of immunocompromised state, IV drug abusers. We want to look for trauma, older patients with osteoporosis, those who may have had a fall or a car accident. These patients need imaging, so we're not grouping these patients into the nonspecific back pain conservative treatment category. So the next step is, of course, to review any laboratory imaging data or prior records that the patient may come with. However, it's important to note that imaging and diagnostic tests are not a step, at least initially, in a patient presenting with nonspecific lower back pain. So here are some clinical guidelines from the American College of Physicians. This is from 2017, and I'll show you a couple charts from this study later. The guidelines essentially are for non-invasive treatment for acute, subacute, and chronic lower back pain. The emphasis is really on non-pharmacologic therapies, particularly for chronic lower back pain, as we know that opioids tend to be less effective and the risks often outweigh the benefits. So that's why they're giving a stronger caution regarding opioids. Acetaminophen was not recommended for acute lower back pain in this study, although it can be appropriate for some patients, especially those who cannot tolerate anti-inflammatories. And there was really more evidence on mind-body interventions such as yoga, tai chi, and mindfulness-based stress reduction. So these are all very important things that really can make a big difference for the patients. So deciding if lower back pain has a serious cause, because of course, what we're all worried about, we don't want to miss something important, but we don't want to overreact and overly image patients that have non-specific lower back pain. So how do we sort out the two? So some of the things we worry about would be serious lumbar pathology, such as an epidural abscess, a visceral problem, renal lithiasis being a very common one. They can present with flank pain, urinary symptoms. We want to look for patients that have lumbar radicular pain or neurogenic claudication, because that's not axial back pain per se, but those are other clinical syndromes. They may not be emergent, but we just need to understand that we cannot group them with the non-specific back pain category. But important to remember again that non-specific lower back pain is greater than 90% of patients who present to a primary care setting, and that's telling us that less than 10% of all patients require imaging or urgent referral to a specialist. Again, the best way to rule out a serious cause is to listen to the patient and do a good physical exam. It's not advanced imaging, and it's not a specialist referral. And we all know that MRIs are extremely notorious for picking up false positive findings, especially in patients who have had back pain only for a short period of time. And often we end up barking up the wrong tree and over-diagnosing, and as well as over-treating these patients, and I see it all the time. So looking at serious lumbar spinal disease again, really things to watch out for. And I know this is a bit repetitive, but I think it's worth just mentioning a couple more times. New bowel or bladder disturbance, saddle anesthesia, meaning numbness in the perineal region, and lower motor neuron weakness. If a patient has a new onset fever and they're an IV drug abuser, they have a history of cancer, immunosuppression, chemotherapy, recent spinal procedure, or potentially high-dose steroids, these patients also need to be taken very seriously, and I would consider imaging them very early. Cancer history is also concerning for metastatic disease, as many cancers actually present with bony metastases, especially in the spine, very, very common. So that's something that we don't want to miss. Patients that are over the age of 65 with osteoporosis, prior trauma, and steroid use, that's something that we need to image those patients as well, because we're concerned about fracture. And then pediatric patients, those with night pain, weight loss, pain that's been going on greater than 3 months, I would image these patients relatively soon as well. You're a little more concerned about serious pathology in these patients. It's also very important to look for problems outside the spine. Sometimes as orthopedic surgeons, we are very good at looking at spinal pathology in the MRI, but we sometimes can miss things like tumors or cysts in the kidney and other things. But on your exam, it's very important to look for a number of other visceral issues, because we're all doctors first, and we need to really be able to look at the whole patient. Although we all tend to get pigeonholed within our field. So if the patient just looks unwell, you have a bad feeling about this, your gestalt is that the patient just doesn't look right, definitely be more concerned that the patient may be sick, they may have a cancer, they may have an infection somewhere, and you might want to work that up as well. If there's a lack of correlation to movement, such as non-mechanical pain and night pain, pain at rest, we spoke about that with the pediatric patients. This is something else that we want to look for and can be concerning and tell us that something else is going on. Patients with hip joint signs, if the patient has abdominal pulsations, we should definitely be feeling for that. We should be feeling for peripheral pulses to rule out atherosclerotic disease, vascular disease. And then, of course, we have to be concerned for a gynecologic, abdominal, or GU symptoms, as all of these can present with some degree of back pain. Radicular pain essentially means leg pain in a specific dermatomal distribution. It can be associated with sensory loss, diminished reflexes, and myotomal weakness, but not always. And many patients may present with pain, but without any other neurologic findings. Neurogenic claudication, however, means a feeling of leg heaviness or bilateral buttock, thigh, or leg pain It can even be back pain, but generally that back pain is associated with extension and walking and improves with forward flexion. If the patient is alleviated by rest, that tells you that the patient may have more of a vascular claudication issue. If they're relieved with forward flexion, such as what we call the shopping cart sign here, that really has to do with spinal stenosis or neurogenic claudication. And the reason this happens is actually relatively straightforward to understand. If the patient's in extension, the ligamentum flavum, the facet joints, and the disc tend to act to pinch the nerve roots of the cauda equina. If the patient flexes forward, there is some tensile force put on the posterior elements, and this tends to release that and gives them some improvement of their symptoms. So, and there is a vascular phenomenon going on here as well, where they tend to get some ischemic changes in the nerves when they extend. So this is why you see a lot of patients have difficulty walking upright, but they feel better forward flexing. So the question again, is it always necessary to determine a cause? And the answer to that is no. As long as we've ruled out one of these serious issues, or we're able to group the patient into the right category, we don't need to determine a cause, and you can leave that to the specialist. So the recommended approach, again, is to combine clinical features and your strength of clinical suspicion, and consider the consequences of a delayed diagnosis. Forming a basic differential for every patient that walks in the door, I think, is very helpful. There are those with axial or nonspecific lower back pain. There are those with radicular pain, neurogenic claudication, and then finally Cauda equina syndrome, which is, I'll go over the details of that, but it's really one of the few emergencies that you see in back pain. It's really something that cannot be taken lightly. The patient needs to be sent to the emergency department for an MRI and needs to undergo surgical decompression within a very short time period. 48 hours is generally the standard of care, but most surgeons would perform this operation right away and wouldn't even wait that long. And we'll go over a little bit more about what that is and how to look for it. So again, it's important to remember that as long as we're dealing with the nonspecific lower back pain category, most cases will resolve. Around 25 to 30% may go on to have chronic symptoms, and we can pick those patients up relatively easily by considering some of these prognostic tools or questionnaires. And then we want to look at risk factors. Who else is going to go on to develop chronic back pain or pain greater than 3 months, which is how chronic back pain is defined in the papers? And the risk factors, some of them include older age, depression, fear of pain persistence, and compensation claims. And some of these things are actually kind of built into the questionnaires that you'll see for these screening tools. And I'll show one of them in a moment. It is very challenging to identify an anatomic cause. The differential is fairly wide. It could include discogenic pain, facet-mediated pain, which typically is more extension, whereas discogenic pain is more with flexion or prolonged sitting. Muscular and myofascial pain are very common, and the SI joint is also a potential pain generator. However, your focus should really be on patient reassurance and encouraging early activity, not necessarily by trying to figure out, okay, is this discogenic pain, is this facet-mediated, is it muscular? There is plenty of time for that. If the symptoms do not improve after 4 weeks, the patient may then require imaging and other things. But in the beginning, it doesn't really change the management too much, and I would say that it's not really critical, and that's been well shown in the literature. So that, again, the point of this is do not focus too much time and effort trying to identify an exact anatomic cause or a pain generator, but rather treat the patient's symptoms and put them in the right category, and then follow the data. So again, we talked a little bit about this before. I'll just give a little bit more detail about radicular pain. It's radiating leg pain in a dermal tomal distribution. Again, patients may or may not have numbness and motor weakness. It's usually due to a herniated disc. It's generally in younger patients, although you can see this in any age. It's somewhat rare to see a patient in their 80s with spinal stenosis and severe degenerative change and a herniated disc, but it does happen. Sometimes patients can be as young as 10, 12 years old and get a disc herniation, although they can get something similar called an apophyseal ring fracture that can present in a very similar way. It's usually younger patients with a positive straight leg raise, and the symptoms are dramatic. People cannot live with this. They can't walk. They often have emergency department visits. However, even though the MRIs tend to look pretty ugly, patients actually do pretty well, and the majority of patients get better. And we know this, and it's been well proven. So the prognosis of acute lumbar radiculopathy has been looked at in many studies. Two of the more well-known ones, Hercules in 1970, found that 60% of patients were symptom-free at 30 days, found that 90% were symptom-free at 6 months. And this is about what I see in my practice. I would agree with this. There was a Weber study that's also pretty well known from '93 that showed that 70% of patients were symptom-free at 3 months. So again, you're seeing a trend here that about 30% of patients are going to go on to have potentially chronic problems, may require referral to a specialist, may require injections or surgery, but the majority of them do not fall in that category. Which is really important to remember when we're talking to our patients and reassuring them that, look, you have a bad problem, but we know that you're most likely going to get better, and it's very important to remind that patient that life will go on, and they will get through it, but we all know that back pain tends to be very debilitating. Lumbar spinal stenosis is sort of a chronic progressive condition where there is a narrowing gradually of the spinal canal. We talked about the pathology of that a little bit, but there are several structures that are offending. You have the disc anteriorly, you have the facet joints, you have the ligamentum flavum, and some of the details on imaging are a bit out of the scope of this talk, but basically the end result is that the nerve roots of the cauda equina are getting compressed slowly and gradually over time, and even though neurologic deficits are rare, because it's such a slow progressive condition, spinal stenosis is really not likely to resolve or completely go away without treatment. A herniated disc will get better without treatment most of the time, but spinal stenosis is kind of there to stay. It's an arthritic condition. It's kind of like arthritis of your hip. It's not going anywhere. However, we can tell our patients that they're not likely to become paralyzed. They're not likely to be in a wheelchair. There are studies also, such as this one from 2013, demonstrating 70% who had no change or only mild worsening at 11-year follow-up. So that's very important to remember, that we can reassure our patients that their symptoms are going to be very gradual. They may be progressive, but it's very unlikely they're going to develop any significant neurologic issues with this. Cauda equina syndrome, as we talked about before, is kind of like the worst surgical emergency that we see in the lumbar spine. The hallmark of this would be leg weakness and sensory changes, saddle anesthesia, which means numbness in the lower sacral or perineal distribution. They can get bowel and bladder retention, which then leads to overflow incontinence. So Cauda equina syndrome is a lower motor neuron issue, not an upper. So that means that even though bowel and bladder incontinence tend to be a catchphrase that we all use and we see in our notes a lot, but really it's retention that's the main problem here. The patients will retain urine until the bladder overflows, and that's where the incontinence comes from, because they're unable to empty that bladder. So that's very important. If we see that, especially in a young patient with a large disc herniation, that's an emergency. They need an MRI and a Foley catheter right away to decompress the bladder. It's usually a large herniated disc, although there are some other types of pathology that can cause this. And generally L4-5 is the most common level, such as the MRI that we see here, where you have this very, very significant large herniated disc that's kind of filling the canal centrally and off to the left. You can see that the space for the nerves here is very, very small. So this is a herniated disc that I would expect could potentially cause cauda equina symptoms, although sometimes you see a herniated disc like this, and the patient actually has relatively mild symptoms. So that's why we don't treat MRIs, we treat people. But if you do see any of these neurologic symptoms in association with an MRI like this, that is a surgical emergency. So these are the kind of patients, if you're picking up clinically that they have any of these symptoms, yes, they need to be sent to the emergency department right away, and there really can't be a delay in this. Imaging is not required for patients that have nonspecific lower back pain of less than 4 weeks. That's kind of the cutoff that we've seen in the literature. I think that if patients are coming back after a month, they say they tried physical therapy, they tried home exercises, anti-inflammatories, and they're not better, it's reasonable at that point to image the patient, starting with an X-ray, and you might want to consider an MRI too, especially if the patients have neurologic findings at all or any type of radicular pain. But patients can definitely safely be treated without imaging, at least for 4 weeks. Imaging generally will not change primary care management, and it's also been found that if patients, even those that have one red flag, such as fevers, night pain, those guidelines have not really found to be very effective. Generally, it's still safe to kind of manage these patients over the course of maybe 2 to 4 weeks, but it's important to follow them closely, and of course if they are developing concerning findings, then by all means image the patient. This is American College of Physicians guidelines for imaging in patients with back pain. Here up at the top of the screen, we see here that patients who might need immediate imaging, including a radiograph and an ESR, would be anyone with a major risk factor for cancer. An MRI would be needed for patients with a suspected spinal infection, Cauda equina syndrome, which we've gone over, or any severe neurologic deficits. It's okay to divert imaging until after initial treatment if the patient has a weaker risk factor for cancer. They may have risk factors for an inflammatory arthritis. They might have risk factors for vertebral compression fracture. I would definitely consider an X-ray in those patients, but they can often be treated initially without imaging. An MRI is necessary for patients with a radiculopathy or spinal stenosis after an initial conservative treatment period. Again, 2 to 4 weeks is reasonable. And then those that have pain resolved 1 month after treatment or previous imaging, let's say the patient had an MRI several months prior, and there's really no change in the clinical status, so they don't really need to be reimaged. Again, those who you want to image quicker would be those with cancer, those with a fracture or trauma history, anyone with concern for Cauda equina syndrome, or an infection, anyone with concern for infection or epidural abscess, such as this MRI here is showing us a relatively large ventral epidural abscess in the lumbar spine extending from the top of L5 down to the sacrum. This is certainly something that we would expect to be surgical, and it would potentially be an emergency where the patient may be septic, or this could be a life-threatening disease. So, some guidelines. The guidelines from the UK and the United States. The UK guidelines from 2016 and the United States guidelines from 2017 from the ACP. The changes between those guidelines and prior was more emphasis on non-pharmacologic options, a stratified approach on screening scores, and not response to initial management. This is a brief overview of the START back screening tool. So this stands for Subgroups for Targeted Treatment Back Screening Tool. This was a validation study, and patients were given an overall score, 0 to 3 being low risk, 3 to 4 medium risk, and greater than 4 high risk. The objective of the study, again, was to validate the screening tool and to try to identify patients that are going to go on to chronic symptoms in a primary care setting. The low-risk patients generally have a good prognosis and are very safe for primary care management using best practice guidelines. Medium-risk patients, in other words, in that 3 to 4 category in this screening tool, but there are others, have an unfavorable prognosis and may require physiotherapy or a referral. And those that are high risk, or over 4, have a very unfavorable prognosis, require a combination of a variety of different approaches to treatment, and are also likely to go on to have chronic symptoms. And this is some odds ratios from the study, just showing you that some of the things that are significant here include coping strategies, disability, fear avoidance behavior and beliefs, as well as pain elsewhere. So this is an example of the questionnaire. You can see here that some of the things that are on here, for example, how bothersome has your back pain been in the past 2 weeks? You can see that my back pain is spread down my leg, I have pain in my shoulder or neck. But you can see here that, especially with number 4, you start to get into the fear avoidance. It's really not safe for a person with a condition like mine to be physically active. We see a lot of people that are very afraid to go out the door. They don't want to walk. They don't want to see their grandkids. They have back pain and they think that they really should not be active, and that's not true. And we really have to encourage people to remain active. You can see here that number 7, worrying thoughts have been going through my mind a lot of the time in the past 2 weeks. I feel that my back pain is terrible and it's never going to get any better. We've all seen patients that fall into these categories, and not surprisingly, they are at higher risk to have problems and to not get better within they're not going to fall into that 70% to get better within a short time period. This is, again, a chart from this paper from 2017, again going through the diagnostic triage. You can see here that although there's a different study than the one we looked at before, the themes are the same. A history and physical examination is really most important. You want to exclude non-spinal causes, and you can see here that they're talking about hip disease, visceral causes, vascular causes, systemic, and then viral syndromes. And then if these things have been kind of ruled out, then we go through our triage, and you can see here that, again, we have the same numbers. We have non-specific lower back pain, again, being the vast majority of patients, up to 95%. We have radicular pain or neurogenic claudication in the 5 to 10% range. And then we have serious spinal disease, including those things that we don't want to miss, as less than 1% of cases for most primary care practices. You can see that most patients need advice and reassurance. And then there are some variations in treatment depending on which of these categories the patient falls into, and we'll go over that in a bit more detail. Non-pharmacologic treatments include reassurance, which is probably most important. We want to tell the patient to stay active. It used to be 20, 30 years ago. Patients were told to stay on bed rest for weeks. Patients used to come to the hospital and lie down for 6 weeks. As you can imagine, the complication rate and the deconditioning was extremely high. Patients got DVT, pneumonia, all kinds of issues. We want patients to stay active. That's been well proven. We want to consider physical therapy, home exercises. Heat and ice can be effective. And then we want to schedule follow-up in a fairly short time to make sure the patients are getting better. And it's important to remember that most patients with acute or subacute lower back pain improve over time regardless of treatment. So exactly which of these things we choose may not be as important as long as we reassure the patient that this is most likely going to get better. Pharmacologic treatments, again, looking at the sets of guidelines from the UK and the US. NSAIDs were the only medications endorsed by both guidelines. It's good to limit to a 2-week initial course, and you also want to limit these to patients with a favorable renal and GI profile, and to counsel on the adverse effects that we're all aware of, including abdominal pain, GI bleeding, gastritis, hypertension, and so on. Pharmacologic treatments, again, we want to consider the addition of a muscle relaxant, especially if we think the pain may be muscular in origin or the patient has a lot of spasm component to their pain. And you can consider a weaker opioid when NSAIDs are contraindicated. This is acceptable in a very short time. We just kind of want to stay away from opioids in the long term. So here is another summary of the US and UK guidelines. Here you can see that non-pharmacologic treatment up at the top. You can see that the United States guidelines pretty much recommends all of these treatments. The advice to stay active, massage, spinal manipulation versus sham, acupuncture versus sham, and heat. You can see here that pharmacologic treatments, these NSAIDs and muscle relaxants, but there are some differences in the guidelines where in the UK, muscle relaxants were not mentioned in the guideline, whereas they were in the United States guidelines. But this, again, is just kind of an idea about some of the things that are out there for acute lower back pain. So looking at management of persistent nonspecific lower back pain, which is going to be distinct from acute or subacute, this means that patients may benefit from cognitive behavioral therapy. They may need a structured exercise program, and they might need a multidisciplinary therapy. They might need a cognitive behavioral therapist. They might need a pain management specialist, a physical therapist. You as a primary practitioner will still want to stay involved with the care. There are a number of different pieces to this that need to be in place. And you can consider spinal manipulation and acupuncture, although this is lower evidence, it can be helpful for some patients. I was kind of skeptical of acupuncture when I first came into practice, but I have seen patients benefit. I think we all have. And I think that there's a role for all these treatments, but not every patient will respond. You do want to avoid muscle relaxants in the longer term. I think it's certainly acceptable for acute lower back pain, but chronic back pain, generally we don't want to keep patients on muscle relaxants more than a week or two at the most. We can consider opioids as a last resort, but consider ordering imaging and consider referral to a specialist. I don't think it's a good idea to sort of put patients on high-dose opioids and just keep them on them without really having a diagnosis or any kind of goal of treatment. That usually leads to problems. So patients with radicular pain and neurogenic claudication, we want to counsel them to stay active and to start an exercise program. Generally, a Williams or flexion-based program is recommended for those with spinal stenosis, and a McKenzie or extension-based program can be really helpful for patients with lumbar disc herniations, but there is some variability to that, and often the therapist will try to find what works for the patient best. And then we can consider gabapentin or pregabalin or Lyrica. These also can be helpful for patients with any type of neuropathic pain, including radicular pain and neurogenic claudication. I use them fairly frequently, and it can be an adjunct to NSAIDs, muscle relaxants, and potentially a weaker opioid. More invasive treatments that are out there are facet blocks, medial branch blocks, and RFAs. Lumbar epidural steroid injections are very common. RFA is a radiofrequency ablation, which is kind of essentially a burning, or with a catheter, it's a more permanent version of a cortisone shot to the to the facet joints. And then surgical intervention is really reserved for patients that have failed conservative treatment or have progressive neurologic deficits or have any kind of serious spinal pathology. But generally, surgery doesn't cure back pain. And so it's very rare that I would tell a patient who comes in with purely back pain, lacking these other symptoms or lacking radicular pain, that we're going to be able to cure their pain with back surgery. We just don't really say that too often. It's just something that typically doesn't work, and there are a few exceptions, but I think that's also out of the scope of our talk today. Surgery would include discectomies, laminectomies, in other words, decompressions, and infusion procedures. So just wrapping up here shortly, once again, looking back at the guidelines, this is just to show you here, looking at the U.S. guidelines of 2017, that the only things here that were really recommended for radicular pain were exercise and opioids, interestingly, only if non-pharmacologic therapy fails. And you can see here that a variety of other treatments such as antidepressants, epidural steroids, lumbar discectomy, none of these things are really recommended. So again, this is just one set of guidelines, but you can see here that there was insufficient evidence or quite a few treatments that we do routinely. So I would consider referring to a specialist. Use the validated screening tools that are available to you. These include the START back screening tool, the Arebro, a pain questionnaire, and the pickup model. And these are all relatively similar. And using this method of using the screening tools has had modest results, at least, in randomized controlled trials. Again, if the patient has Cauda equina syndrome, progressive neurologic deficit, if you sense that the patient is myelopathic, they might be hyperreflexic or have some bowel bladder issues, or you detect that they may have a spinal cord dysfunction, those generally are going to need to be imaged and referred out. Those with more chronic symptoms, just so that you can get a treatment plan in place, a definitive treatment plan, and not kind of spinning your wheels with these patients. And those with any kind of spine fracture or malignancy on imaging, rather than potentially a routine compression fracture in an elderly patient that probably you're very used to managing well. But anything more complicated, you might want to send that to a specialist. So just to summarize what we talked about tonight, the best tool, again, is a thorough history and physical. You want to triage nonspecific lower back pain, which again is going to be at least 90% of your patients, versus those with neurologic deficits or serious pathology. Reassurance, counseling, and a slow return to normal activity are very important, using the less is more treatment regimen. It's not necessary to establish an exact pain generator in cases of nonspecific lower back pain, and we talked about that in some detail. And of course, the presence of Cauda equina syndrome or any multiple red flag symptoms would require an urgent referral to a specialist. And thanks very much. I think that's it. And I think we have a little time to go over some questions if anyone has a question for me. Thank you.
As a reminder, text chat is located on the right-hand side of your screen. To submit a question, type your question in the small text box at the bottom, and when finished, click the send button. Please note that due to time constraints, our panel may not respond to all questions submitted.
Okay. Right now I have just one question from the audience, and it says management of non-traumatic sacrococcygeal pain. So I assume the question is how do we manage non-traumatic sacrococcygeal pain? So I think that is can be kind of a complex topic. That coccydynia is a relatively well-known chronic pain syndrome. There are actually coccydynia societies for patients, sort of support groups, because the pain can be very overwhelming to them and often can be centralized. There can be a history of remote injury with these patients where they may have had a fall onto their buttock area, or sometimes it was from bicycling repetitively, or Peloton, something like that. And generally, initial course of anti-inflammatories, of reassurance, something like a donut pillow can be useful to keep the pressure off during sitting, which is usually the most uncomfortable the patients are. And most of these are going to heal with time. It is helpful sometimes to get an MRI to see if there's persistent edema at the sacrococcygeal junction. Pain management and physiatrists, they're pretty good at doing injections to the area, which can be very helpful. And I think that in very rare cases of recalcitrant pain, a coccygectomy can be necessary, and it can actually work well for select patients, but I think we do that very uncommonly because the majority of patients will get better and will not go into chronic pain. But I think pain management specialists or physiatrists would be generally very good at targeting that area and performing injections, which is usually going to be necessary if they don't get better with a couple weeks or maybe 2 or 3 months of conservative treatment. We have another question. The question is, one of my gripes with seeing an orthopedist for back pain or any other pain is that most of them have forgotten how to do the physical exam and strictly rely on diagnostics. Very frustrating. I agree. I think that absolutely right, that your point is very well taken. I hope I tried to touch on that a little bit in the talk tonight, that I think that because MRIs are such a good test and they really show us so much detail of the spine, a lot of us feel that we might be able to get away with relying on an MRI rather than really looking at a patient, and we're very likely to miss a lot of things if we do that. So I think that we should all really go back to our basics with really getting a good history and a physical, and so I think that's a good point and well taken. There's another question here. Can you comment on sacroiliac pain and joint dysfunction as a part of lower back pain? So sacroiliac pain is pretty common. There are some studies looking at this that have shown that SI joint pathology or sacroiliitis can be responsible for up to 20 to 30% of all patients with back pain, and some studies even more than that, although I'm not sure that I believe that. But it definitely is a common condition. The sacroiliac joint is really a fixed joint. It's only about 1 millimeter wide and has some very strong ligaments that attach it, so there's really not a lot of motion to that joint, but there is stress on it. Very frequently we see patients with a lumbar fusion or some type of fixed, the vertebrae are fixed together at the lower lumbar area. Often we'll transfer stress. Instead of being able to transfer stress to another disc, they'll transfer it to the SI joint. That's pretty common. SI pain is common. It's important to look for it. There are essentially 5 physical exam findings that are indicate a patient may have SI pain, and if those are positive, then patients can benefit from physical therapy, but they also very often need to be referred to a pain management specialist. A diagnostic injection in the SI joint under X-ray is really the best way to diagnose that, and it can be very hard to figure out because as the SI joint is very close to the lumbosacral facets, it's very close to a number of other structures in the area that may cause pain. So it can be challenging based on just physical exam to determine that. We have another question, which is how to establish work-related lower back pain for workers' comp patients with lower back pain. Well, I think this can be complicated and it's not always straightforward, but I think the most important thing is to listen to the patient. And I think if the patient, some cases are going to be very, very easy to determine. If the patient was completely fine before and they may have had they tried to lift a 150-pound bag of concrete and they had a severe back pain right after and they required further treatment, that's fairly clear cut. But there are a lot of other patients that have for example, chronic repetitive injuries at work, those related to postural issues or maybe a non-ergonomic chair. Those can be very, very difficult to figure out. And often patients have degenerative findings on an MRI, and then we're trying to figure out, are these degenerative findings related to the work injury or are they related to the normal aging process? And that's something that's very loaded because a patient with a workers' compensation claim may have a lot going on that's going to prevent them from potentially wanting to get better. Maybe there's litigation involved with a car accident, things like that. So I think that it's listening to the patient and also using common sense and trying to look for other things that may have caused this injury or this pain. And if you kind of rule those out, then I think that I certainly would try to side with the patient and if they did have a significant injury. But it's a complicated topic. Thank you for your question. We have another question here. Also, do you see SI pain in those with Ehlers-Danlos syndrome commonly? I personally haven't seen SI pain in those with Ehlers-Danlos syndrome commonly. That's not something that I have a lot of experience with as far as SI pain, but it could certainly occur. It can be associated with a number of systemic diseases. Ankylosing spondylitis would be the most common one, where we see a fusion of the SI joints and very early on in the process, often in young males, and they will go on to get fusions in the lumbar spine, the hips, but the SI joint can be the first place to see that. So I think that would probably be, ankylosing spondylitis would probably be where I see that the most. But I don't have too much experience with the Ehlers-Danlos. It looks like those are all the questions that we have. If anyone else would like to ask a question, we have a few more minutes. Otherwise, thank you all very much for your attention.
Thank you, Dr. Harris, for your time in that presentation. And thank you to our audience for your attendance. On behalf of Atlantic Health System, Morristown Medical Center Orthopedic Surgery, and the Department of Orthopedics at Chilton Medical Center, I would like to thank you for your participation in today's event. You will now be redirected to the post-event survey requesting your feedback. Please take a moment to complete this survey in order to receive credit for providing feedback and attending today's webinar. This concludes today's program. Thank you and have a great day.